again, and welcome to the final day of EULAR 2022. My name is Douglas Veale. As this is the 75th anniversary Congress, which is coming to an end, I'd like to review what I felt were some of the posters of interest from the CSF perspective on this final day. The main focus today of the posters selected is axSpA and PSA. And I hope that, as I did, you will find these highlights both interesting and informative. Initially, we're going to focus on the efficacy and the safety in axSpA, and 3 posters focused on spondyloarthritis efficacy, which I found of special interest. That from Desiree van der Heijden and colleagues provided efficacy and safety data from the phase 3 trial on upadacitinib in patients with active ankylosing spondylitis that was refractory to biologic therapy. Furthermore, there was 2 additional posters which focused on secukinumab from Braun et al, reporting on radiographic progression and the course of inflammation over a period of 2 years in the PREVENT study. And then from Cozy et al, presenting 24-month data from a real-life study on the safety and efficacy of secukinumab in axial spondyloarthritis. So if we look at Desiree van der Heijden and colleagues, first of all, the efficacy and safety of UPA in patients with active ankylosing spondylitis that was refractory to biologic therapy. And this is from the SELECT AXIS-2 trial, which includes 2 separate studies, one for AnkSpond with biologic DMARD inadequate responders, and one for non-radiological axSpA. Over 420 randomized patients with active AS were assigned to treatment with UPA 15 milligrams or placebo, and 409 patients, that's 97%, received the study drug through week 4. The primary endpoint of this study was ASAS-40 at week 14. And as you can see here, the key results was that 45% of UPA-treated patients versus 18% of placebo-treated patients achieved ASAS-40 response at week 14. So this highly significant result showing a benefit for UPA over placebo in these refractory biologic treated patients. UPA also showed onset of effect at a very early stage, as early as week 4, and this was statistically significant also. The rate of adverse events was similar between the treatment groups through week 14. So I think this is a very positive result for UPA in a longer trial of patients who were selected for being inadequate responders to biologic therapies. So in the next study, as I mentioned, from Braun et al, they looked at secukinumab and the effect of secukinumab on radiographic progression and inflammation in sacroiliac joints and the spine in patients with non-radiographic axial spondyloarthritis. And again, this was a 2-year study looking at the outcomes of a phase 3 randomized trial, the PREVENT study. Over 550 patients randomized to receive secukinumab 150 milligrams with or without a loading dose, interestingly, or indeed placebo. And they looked at radiographs of the spine, and the sacroiliac joints were collected at baseline and 104 weeks, where MRIs were actually collected at baseline, week 16, week 52, and week 104, or essentially 2 years. So 98% of patients treated with secukinumab 100 milligrams showed no structural progression. That's almost 100% of patients showed no structural progression over the treatment period. Sacroiliac joint radiographs showed that 88% of patients on secukinumab and 86% of placebo-treated patients had no progression in SIJ joints by 2 years. And the secukinumab reduced sacroiliac joint bone marrow edema score versus placebo at week 16 and week 52, with sustained reduction through week 104. So this is evidence really that secukinumab is having a profound effect, almost 100% inhibition of structural progression and reduction of bone edema, which correlates with activity in the sacroiliac joints at week 16, week 52, and continued through to 104. The next study from Cozy et al. Looks at the effectiveness and safety of secukinumab, again in axSpA patients, again a 24-month study, and this time it's from a prospective, multi-center, real-life study. So these are real-life patients from a multi-centric Italian cohort, and they also looked at drug retention rate, low disease activity scores, defined as BASDAI less than 4 and an ASDAS less than 2.1. And the key results, after 20 months of treatment, 90%, over 90% of naive and over 75% of non-naive patients achieved low disease activity. So again, very significant response rates here over a longer period of time. And naive patients showed better physical functioning and lower disease activity scores than the non-naive patients. The retention rate of the drug was 75% in the whole population, though there were some differences depending on gender. And I think it'd be really important to actually analyze that in more detail. And we look forward to those results in the future. So I mentioned yesterday a study of bimekizumab. Here we have bimekizumab in patients with active non-radiographic axSpA from study results from the B-Mobile 1 study, a phase 3 multi-center randomized placebo-controlled study from Zenon Bariliakos and colleagues. This is essentially the primary outcome in this study was an ASAS 40 at week 16, and secondary endpoints were included but not limited to ASAS 20 and BASDAI. So this study showed that bimekizumab gave a 47.7% ASAS 40 response rate in the axSpA patients, whereas 21.4% of the placebo-treated patients responded. Slightly higher placebo response rate than you'd like to see, but still almost double the response rate in the active treatment group with bimekizumab. Responses were rapid with bimekizumab, as you might expect, and that was true for the placebo patients who switched to bimekizumab at week 16 also. So one mention for today, also relating to secukinumab, though I won't go through the poster in detail, from our friend Maxime Dugados again and his colleagues carried out a retrospective study in France collecting data from October 2019 to September 2020 to assess whether the presence of objective signs of inflammation were predictive of secukinumab retention at 1 year in axSpA treated patients. And they identified a number of predictive factors, including prior exposure to TNF inhibitors, inflammatory bowel disease as a comorbidity, and a history of depression as a comorbidity as predictive factors of secukinumab retention. So that's interesting. The objective signs of inflammation did not predict adherence, but these factors did. Another mention for today was the poster from Laura Gosek and colleagues entitled Time to Improvement of Fatigue in Patients with axSpA in a study of tofacitinib. We know how important fatigue is as a symptom to our patients, and we know that tofacitinib as a JAK inhibitor has got a very good effect overall in these patients. But Professor Gosek and colleagues in this post hoc analysis estimated the time to improvement in fatigue in these patients and determined, according to the FACIT-F total score, that these patients actually responded faster and in a larger magnitude compared to the placebo patients up to week 16. So that's really interesting, and it means that the response rates in tofacitinib that we've seen in other studies are true in patients with ankylosing spondylitis, and it's also true for the symptom of fatigue. So that's very encouraging. Safety in axSpA is important, obviously. We're looking at the safety perspective here from Deodar and colleagues, and they provide results from an integrated safety analysis of tofacitinib in axSpA in clinical trials. So the study from et al. And colleagues, as I mentioned, it was a safety profile analysis of tofacitinib-treated patients from randomized controlled trials with active AS. And this was essentially a post-hoc analysis. And they found that the most common treatment emergent adverse events were nasopharyngitis and upper respiratory tract infection. And I suspect that you, and as I would agree, that these are probably the most common treatment emergent adverse events that we see with any study, actually, of any treatment. Interestingly, the serious adverse event rates were higher with tofacitinib 5 milligrams BD than the placebo in week 16, and similar in the week 48 tofacitinib cohorts. Discontinuation due to adverse events was similar between groups in the week 16 placebo-controlled cohort and the 48-week tofacitinib cohorts. Now let's switch the focus to psoriatic arthritis briefly from axSpA, and Professor Philip Mees and colleagues presented evidence on assessing PSA by disease domain using real-world data from the core Evitas PSA-SPA registry. Their data highlighted the importance of assessing all the PSA domains for optimal disease management. Also, with regards to disease management, in the final poster of this podcast, Georg Schett and his colleagues assessed the effect of gozulkimab on serum biomarkers in patients with PSA and an inadequate response or an intolerance to TNF inhibitors. So first of all, Phil Mees' study, the real-world evidence from the core Evitas database. This was looking at adult patients with psoriatic arthritis who initiated therapy between January 2013 and December 2020, so over a 7-year period. And it included patients who were initiating treatment with TNF inhibitors or IL-17 inhibitors. The most common disease domain combination overall, which represented 14% of the total group, was peripheral arthritis, nail psoriasis, and skin disease. And the frequency of the top 3 most common domain combinations were similar among all therapy groups. So these patients presenting with this triad of domains were treated with equivalent numbers of different treatments across the treatment modalities. Overall, peripheral arthritis and skin disease were the most common concomitant disease domains, which I guess is not surprising, and the results were similar by therapy group. So that's quite an interesting, from a large cohort, quite interesting real-world evidence in relation to psoriatic arthritis patients treated with TNF inhibitors or IL-17 inhibitors. The study from Georg Schett and group was taken from the results of the Cosmos study. This was a clinical trial of gozulkimab treatment in patients who had an inadequate response to TNF inhibitors over 18 years of age with active PSA that is greater or equal to 3 swollen and tender joint counts. And they received different dosing regimes of gozulkimab or placebo with the proviso of an early escape at week 16. So quite a standard clinical trial design here. They took samples, though, for serum biomarker analysis at baseline, week 4, week 16, 24, and week 48 from those patients who consented. And they compared these biomarkers with healthy control serum samples. And they were looking at associations between early biomarker changes and baseline disease activity, between early biomarker changes and gozulkimab treatment, and clinical response at week 24. So through week 24, significant decreases from baseline were observed in levels of C-reactive protein, serum amyloid A, IL-6, IL-17A, IL-17F, and IL-22 in the patients treated with gozulkimab, but they were not seen in the placebo-treated patients. So that's very interesting information, I think very useful information to show that the active drug was having an effect at the molecular level in these patients. Furthermore, reductions in IL-17A, IL-17F, and IL-22 in the gozulkimab treated patients were significant by week 4, and they further decreased by week 16, and this change was sustained through week 24 and week 48. So these biomarkers are reduced with response at an early stage, and they are reduced over time as the patients continue on their therapy. In the TNF inadequate responder patients, gozulkimab treated patients achieving an ACR 20 at week 24 exhibited higher IL-22 and interferon gamma levels at baseline compared to non-responders. So that's interesting data, and I think in this small initial analysis, it does give us hope that biomarkers may help to identify patients who will respond to specific therapies in the future. So I have one final mention for today's roundup, which is from Professor Camilla Svensson. And if you haven't seen this presentation, I recommend that you try and catch it if you can. It's on neuroinflammation and neuropathic pain mechanisms in rheumatoid arthritis. So that brings us to the close of another insightful day at EULAR 2022, and really this is an end to a great congress with more relevant cytokine signaling content. I hope you've enjoyed all the highlight sessions from this year's meeting as much as I have. And again, I stress that if you haven't already done so, you can download the highlights of EULAR 2022 from cytokinesignaling.com to see the abstracts that we've selected for you for the whole Congress, and also along with some of the top picks that we have discussed. That just remains for me to say thank you for joining me today, and I look forward to more sessions and podcasts with you through the CSF in the future. So thanks very much, and safe travels.